Hello and welcome back to this discussion on endocrine emergencies. I'm Professor Adam Thompson. Let's get started with this last and final video. So another endocrine disorder could be a growth hormone pathology, where the anterior pituitary gland secretes growth hormone. The problems associated with growth hormone secretion include both oversecretion or undersecretion. And you can imagine oversecretion of growth hormone would cause somebody to be larger, somebody with gigantism, such as Andre the Giant, pictured here on the left. And somebody with undersecretion of growth hormone may present with dwarfism, such as the person you see on the right there, Tyrion Lannister from Game of Thrones. Obviously, they are both extremes of the conditions. They are rare conditions and usually the result of a tumor. Oversecretion results in acromegaly, a condition usually diagnosed in young adulthood. And again, gigantism can present with abnormally large hands and the face. You know, those jaw bones come down and look a little bit stronger. As well as their facial characteristics. Undersecretion is rare and is characterized by delayed development and growth. Again, the lack of treatment could lead to dwarfism. So we're going to talk a little bit about hypothyroidism and hyperthyroidism. Hypothyroidism is a decrease in metabolism, and hyperthyroidism will cause an increase in metabolism. Approximately 20 million Americans have a thyroid disorder. Graves' disease is most common type of hyperthyroidism, and it increases the metabolism. So they have a hypermetabolic state. It's the most severe type of hyperthyroidism as well, and it's 10 times more common in women. All right, so much more common in women over men, and it tends to follow a chronic course of remission and relapse, and it may be fatal if not treated. The autoimmune disorder in which the thyroid gland hypertrophies or enlarges as its activity increases is known as Graves' disease. It produces a visible mass in the anterior part of the neck. This sometimes can lead to what they call a goiter. Overactive gland secretes an excessive amount of thyroxine. Thyroxine is kind of the culprit here. And other signs and symptoms may include an increase in appetite with obviously marked weight loss because of the hypermetabolism, polydipsia, exophthalmos, where their eyes start to bulge out of their skull, pretibial myxedema, which is an orange peel appearance, and non-pitting edema of the skin on the anterior part of the leg below the knee. And then increased stress on the heart may actually lead to heart failure because that hypermetabolic state comes with it some tachycardia, increase in blood pressure, and all the things associated with sort of a hyperstimulated state. Hashimoto's disease is another cause of hyperthyroidism. It's also more common in women over men. Results in the infiltration of T lymphocytes and plasma cells. It's an autoimmune disorder that affects the TSH, which is the thyroid stimulating hormone receptors. And hypothyroidism will follow after antibodies destroy the follicles. MYXEDEMA coma occurs if the supply of thyroid hormones become inadequate. Organ tissues do not grow or mature, and then energy production will decline, and actions of other hormones are also affected. The adult hypothyroidism is sometimes called myxedema. Patients often have localized accumulations of mucinous material in the skin, and it's manifested by a slowing of the metabolic process. All right, so hypothyroidism or myxedema is a slowing of the metabolic process. So if you picture the opposite sort of hyperthyroidism, you'll get some of those same changes. So where hyperthyroidism will cause weight loss, hypothyroidism will cause more weight gain. The symptoms may be exhibited by all organ systems. The severity is going to be consistent with the degree of hormone deficiency, and it could include fatigue, feeling cold, again, weight gain with hypothyroidism, dry skin, sleepiness. It's often subtle and can be mistaken for other conditions as well. So the continued decrease of hormone levels will actually lead to what they call myxedema coma, and it's accompanied by physiologic decompensation that leads to peripheral vasoconstriction. It often is precipitated by things like infection, exposure to cold, trauma, surgery, and even certain medications. The hallmark, though, of myxedema coma is the deterioration of mental status, that coma part, right? Most cases occur during the winter in women older than 60. So women older than 60 usually get this during the winter because of the extreme cold. Consistent finding is hypothermia. Absence of fever in the presence of infection is common. All right, so they might even be septic without a fever. They'll be afebrile with an infection. Hypothyroidism decreases intestinal motility, so associated with a decreased metabolic rate. It's overall decreased metabolic rate. MYXEDEMA coma is a metabolic and a cardiovascular emergency. If not diagnosed and treated immediately, the mortality rates are approximately 40%. Almost half of these patients end up dying if they're not treated immediately. As with all of these endocrine emergencies, MYXEDEMA coma is going to require supportive care. You're going to treat the condition that you find. So you might not know that they have hypothyroidism or they're suffering from MYXEDEMA coma. However, you know how to treat a patient. So intubation and ventilation may be indicated. They have an altered mental state. They may even be completely comatose. So assess and manage their airway as indicated. Monitor their cardiac status because hypotension is common amongst these patients and they may respond well to IV crystalloids. If not, consider a vasopressive agent like norepinephrine or dopamine or even an epinephrine drip. You're going to want to treat the hypothermia, but treat it passively, passive rewarming. Remember that they have hypothyroidism and the cause of the MYXEDEMA coma is potentially or very commonly hypothermia, so rewarm them, but don't aggressively rewarm them because that can cause vasodilation and even more hypotension. Active rewarming is necessary for hemodynamically unstable patients with profound hypothermia. All right, avoid sedatives, narcotics, and anesthetics if possible. All right, again, moving from hypothyroidism over to the next thing, thyrotoxicosis, which is sort of the opposite of hypothyroidism, back to a type of hyperthyroidism. It's a toxic condition caused by excessive levels of circulating thyroid hormone. It may be caused by hyperthyroidism, a goiter, autoimmune disorder, or thyroid cancer. Thyroid storm is rare, but it's a life-threatening condition, and it may occur in patients with thyrotoxicosis. It's usually triggered by a stressful event or an increased volume of thyroid hormones in the circulation, and it may present with the normal signs and symptoms of hyperthyroidism, as well as a fever or severe tachycardia, nausea, vomiting, an altered mental state, or even heart failure. And it may be somebody that goes into a reentry tachycardia that you have to treat. Often, even pre-hospitally, beta blockers are a treatment of choice for these patients. Hyperparathyroidism is marked by an increase in parathyroid hormone, which results in an increased level of blood calcium, hypercalcemia, and decreased phosphate levels. The primary cause results from the gland itself, and secondary causes occur somewhere else in the body. Most common cause is a benign neoplasia on the gland, which is called an adenoma. Some more signs and symptoms of hyperparathyroidism include fatigue, weakness, nausea, vomiting, confusion, the pathologic fractures secondary to the thinning of the bones or kidney stones due to the calcium changes. Surgery to remove the enlarged gland is the definitive management. Obviously, that's not done pre-hospitally. It's a more chronic condition that's going to be done at the hospital. Patients with mild forms require monitoring of their calcium blood levels, and pre-hospitally, we're just going to manage airway, breathing, circulation, and provide supportive care. Again, you're treating what you find. You may not know that they have hyperparathyroidism. You just need to know that this condition exists, and you're going to treat the symptoms as you find them. So this patient may present with nausea, vomiting, confusion. So you're always going to do your AEIOU tips on your altered mental state patient, get your blood glucose, identify the cause of their altered mental status if possible, and then treat the nausea with some antiemetics to limit the vomiting if possible, and maybe even replenish their fluids if they become hypovolemic due to dehydration. Next up, we have a pretty difficult condition to pronounce, panhypopituitarism, which is an inadequate production or absence of the pituitary hormones, including your ACTH, which is adrenocorticotropic hormone. Remember, that acts on the adrenal glands. Cortisol, thyroxine, again, that's your thyroid gland. Luteinizing hormone, very common in women. Follicle-stimulating hormone, again, FSH in women. Growth hormone, we talked about growth hormone disorders. And then ADH, or antidiuretic hormone. The clinical presentation varies depending on which one of those hormones they're lacking. Next up, we have diabetes insipidus and SIADH. Diabetes insipidus was not included in the other lecture on all the other types of diabetes because it's totally different. Diabetes insipidus and SIADH are some of the same characteristics as diabetes mellitus. However, it's not a pancreatic pathology. The body is unable to regulate fluid caused by a lack of ADH or antidiuretic hormone. Central diabetes insipidus, or the kidneys are unable to respond appropriately, which is called nephrogenic diabetes insipidus. ADH causes the kidneys to retain water. That's what it does. It's antidiuretic, so it stops diuresis. The lack of ADH causes increased urination, right? So if you don't have an antidiuretic hormone, you're going to have increased diuresis. And this is seen in diabetes mellitus as well. One difference in DI and DM, between DI and DM, diabetes insipidus and diabetes mellitus, is the amount of glucose present in the urine. With diabetes insipidus, it's very diluted, not much glucose in the urine, where with diabetes mellitus, we know that there's a lot of glucose in the urine. Dehydration and electrolyte imbalances may occur. Risk of water intoxication and hyponatremia are also possible. In extreme cases, hypotension will occur, and management may include synthetic ADH, known as vasopressin. That is antidiuretic hormone. In SIADH, the syndrome of inappropriate antidiuretic hormone secretion, excess of ADH results in decrease in urinary output and a systemic fluid overload. So with SIADH, you have too much ADH and causes fluid retention. It may cause hypertension, tachycardia, hyponatremia, seizures, and confusion. Remember, hyponatremia, because you have an increased amount of fluid, it's going to dilute the amount of, so you're not eliminating the sodium. However, the amount of sodium is decreased proportionately because more fluid, less sodium proportionately. Management may include loop diuretics and hypertonic fluids. Here's a simple table that kind of explains both diabetes insipidus and the syndrome of inappropriate ADH secretion. With diabetes insipidus, you have a decreased level of ADH. With SIADH, you have an increased level of ADH. Polyuria, or too much urination, with diabetes insipidus. With SIADH, you'll have oliguria, which is almost no urination. Dehydration and hypotension, very common in diabetes insipidus, and then overload of fluid with SIADH. So they're kind of polar opposites of each other. And with that kind of ends our discussion on the endocrine emergencies. Please watch all 5 videos if you haven't already, and you'll be a master at managing and recognizing these endocrine emergencies.